Very good evening. Thank you for joining me on YouTube. It's time for our 8 p.m. discussion. And what an interesting thing we have to talk about. We woke up this morning to information that the ICMR, or the Indian Center for Medical Research, has really been largely the regulatory body for everything that we're doing so far. The ICMR had put out a letter to a certain number of hospitals saying that the top priority projects, the topmost of the government was the vaccine for COVID. Obviously, given that we are now past 6 lakh cases in India altogether. Now, they have said that Bioethics, which we talked about in a previous story that I had done, which is in Hyderabad, had developed a vaccine candidate and would now hit human trials. But here's the interesting thing. It also said that it's very likely to launch the vaccine for public health use by the 15th of August 2020. Now, look at the date today. All of us who read it said, wow, really, we have a vaccine by the 15th of August for public health use, which means that it will be widely available, mass produced, we can all take it, and life can go back to normal. But it was then that the medical experts turned around and said, hey, something is wrong. This timeline doesn't seem realistic. A lot of the doctors we've been speaking through the day have said that it doesn't seem possible at all for the vaccine to be publicly available by the 15th of August, especially given where we are today. Now, here is why, and let me take you through a quick recap of the process of the steps it takes to make a vaccine available. Now, remember, vaccines are different from tablets like a paracetamol or something like that. A vaccine is meant to give you protection for a certain amount of time. So the first thing that happens is the actual strain of virus is isolated, and they create a vaccine that will cause antibodies to be developed in your body. Apparently, we're already at that stage. Initial tests have confirmed that Bioethics Covaxin does in fact work. It will now hit human trials. Now, what happens when you have human trials? It happens in 3 phases. First, to check if the vaccine is safe. And this is done on a really small group of people, a few, maybe less than 100 people, to check if the vaccine is safe. The second stage is to find out if the vaccine works, which means, does it have efficacy? Does it do the thing it was meant to do? Does it in fact give you protection? And the third phase of trials, which goes up to many, many years, is to find out what dose to give you. Once a year, once in 2 years, once in a lifetime? Does it need booster doses? How do you react to it if you're elderly, if you're pregnant, if you're a child, if you have other problems already existing? Do people from different parts of the world react differently to it? All of these things, and this is normally done over the course of a decade. Because if I give you a vaccine today and I want to find out if it's still going to work 2 years from now, 3 years from now, 4 years from now, that needs to be the length of the trial. So altogether, a vaccine trial takes upwards of a decade. So vaccines that we use against tuberculosis, against polio, against other such diseases take decades to develop. And then, of course, there are the permissions that they have to get to actually use this on human beings, to mass produce it. And then mass producing the vaccine itself, we understand, takes upwards of 6 months to set up and get ready. Now, initially, the WHO said that it would take us 18 months from February this year to get a vaccine. We know that there was a vaccine in Oxford that has been worked on that they hope will be ready by the end of the year, maybe January next year. But August 15th is something that made us all sit up and take notice. Is August 15th actually possible? And here are the questions we're asking about Covaxin today. 1, how close are we to actually having a corona vaccine? And by we, I mean in India. 2, does the timeline seem realistic of August 15th? And 3, should the ICMR be expediting the vaccine trials? And here's what I'm asking this last question. We are in the middle of a healthcare emergency. The cases are increasing. People are dying. There is a perfectly valid explanation and a reason to speed things up. But should they be speeding things up, and at what cost? That's the question that we're asking today. And to help me answer the question, my team has put together a great panel of experts. We have Dr. Sanjeev Bagai, who is a Padma awardee and someone I respect personally a great deal. We also have Dr. Anant Bahn. He's a researcher, global health, bioethics, and health policy. Dr. Tanmay Mahapatra is an epidemiologist, and Dr. Shashank Joshi is an endocrinologist, and he's the Dean of the Indian College of Physicians in Mumbai. Doctors, thank you so much for joining me on this conversation. Let's get straight to our first question. Does the timeline, how close are we to getting a vaccine, and does the timeline seem realistic? I will start with Dr. Bahn. Dr. Bahn, you tweeted about this quite a bit this morning as well. You seem uncomfortable with these timelines. Could you tell us why?
Thanks, Faye, for having me. Yes, so I mean, again, all of us are very much in favor of vaccine research. We are, I think all of us are supportive also of innovation in the country. We all want Indian vaccine companies and Indian vaccine research to progress. But that cannot be at the cost of ensuring that we are following due processes and protocols. And, vaccine research, especially for a novel virus and also with a candidate which has not been tested for COVID-19 earlier, will take time. So if we take too many shortcuts and we don't follow due processes, getting the right approvals at the institutional level, identifying the right clinical trial sites, identifying the right participants, ensuring that they are consented in, ensuring that the data that we are collecting is of good quality, that the endpoints that we are collecting data on are adequate in fashion, and that analyzing that data, using that data to then take decisions about future phases. All of that takes time. And that is why, it's not something which can be done overnight or even practically in 45 days, right? The only data we have so far in terms of what has been put out is only information for phase 1 and phase 2. But typically, you would also need to do efficacy studies, which require a much larger sample size. So I don't think any of that is possible, or actually the combination of all of that is possible to do by the 15th of August, which is why I think most of us are a bit surprised and amazed at that kind of timeline being set up by ICMR. Because, that does raise a lot of questions around how is this going to be done? How are you going to expedite all of that processes, and how are we going to get to an endpoint where you can announce efficacy of the vaccine on 15th of August? Because some element of language in the letter seems to indicate that you're presupposing that you will find success through all of these phases, and you will have a vaccine ready for public use by the 15th of August, which, is very, very surprising for many reasons, as I pointed out.
Dr. Bagai, are you in agreement?
I'm stunned, actually. Okay, so just let me, for all the viewers, just let me briefly describe, with your permission, Faye, just give me 3-4 minutes and I'll just lay out certain important points for all the viewers. We all know it as doctors, but I think a larger section of India would like to know what it is. See, vaccination in the last 3 centuries is one of the greatest discoveries ever made. Right from 1796, when Edward Jenner made the first vaccine, without doubt. We need a vaccine for COVID. That's a no-brainer. But the vaccination schedule, in terms of a process, in terms of SOPs, has to follow a certain path. Very quickly, it's first the genomic phase in a lab, then it's the animal studies in the lab. Once it's cleared with that, then you come on to a human phase. A human phase goes, which we call as phase 3, is in 3 parts. One is a small cohort of about 50 to 100. Then you reach a group of 1,000. Then it's 5,000 in different categories, age-wise, comorbid-wise, sex-wise, and so on. Now, the questions really with this is, when you give a vaccine, that means you are giving a particular protein challenge to the body to make antibodies against the original antigen, which is a foreign particulate such as COVID. Your body takes that much time, nature takes that much time, your human cells take that much time to build a response after the vaccine. So there is no vaccine which you give today and is totally protective by next morning. Now, at the present moment, this vaccine with the timelines, I'm not going into the ICMR letter. The ICMR letter was more a dictatorial letter that either you do it or else. But coming to the medical facts, we don't know what dose. We don't know which age groups this is going to be valid from, which age to which age. The indications and contraindications, that means which are the groups which are not to be vaccinated. So to give you an example, do we take any specific precautions with regards to people who are immunocompromised or in pregnancy or in small children? Is the immunity which is built with this vaccine, when does the immunity kick into the body? That means when do you reach a critical threshold of the antibody levels, which we call as antibody titers? Do we need any boosters? When do we start assuming that this is going to be a protective phase post-vaccination? Is it intramuscular? Is it subcutaneous? What is the cold chain maintenance? What is the temperature control? What is the minimum concentration level which you require of the drug in a vaccine? We don't know whether the neutralizing antibodies are going to be tested on day 7, day 14, day 30, day 70. We don't know what the adverse drug reactions are. Are there any side effects? Are there any complications? Is there any known allergies which are going to be precipitated with this? That means which are the adjuvants? Adjuvants are the stabilizing part which you put in a vaccine. Just 2 minutes more, Faye.
Yes, let's go.
We know that this is an inactivated vaccine. Can this vaccine be given alongside on the same day, not in the same syringe, but with some other vaccines? That means, are some vaccines workable with some others or not? We don't know what the response to this is with regards now the understanding of COVID, with regards the angiogenesis, the thromboembolic phenomena, the vasculitis phenomena. We don't know how these antibodies are going to give a response to the so-called cytogenic storm. And in this, I'll just mention 2 very quick points. We also don't know whether it's a single dose vial or a double or a multi-dose vial and so on. Now, a cytogenic storm, there is a recent article which is published just day before yesterday in JAMA, which shows that the level of interleukin 6 and interleukin 1 has no correlation to the severity. So we may keep testing till the cows come running home, but the fact is what's happening in the lung is not depicted in the blood test. What level of antibodies are actually required, we still don't know. Do the patients of post-COVID, that means you have had an unfortunate episode of getting COVID, whether it's your in home isolation or indeed admitted in the hospital and recovered, are the patients after recovery of COVID still requiring the vaccine? That's the golden question. That means I'm opening a separate gamut here, a Pandora's box, that are you going to be liable for a relapse or are you going to be liable for a reinfection? There are 2 separate things. Now, there is another study which has been published in Nature International, which is 29th June dated, which has shown post-COVID infections, 33% of people had lower immunity at 14 to 20 days than protective. 3/4 of them had partial immunity. That's after the natural infection. And only 1% built up adequate immunity at the end of 2 months. Meaning to say, if you're going to mimic, that means a passive immunity with this vaccine, what is the percentage of population which is going to gain immunity? Now you give a human trial phase, which is beginning, and you built up from 100 odd to 500 to 1,000 to 5,000. It's a monumental task which Dr. Anant has beautifully described as to the data analysis. This is not just 1 point data. This is a huge amount of correlation of data analysis, which you will need a very sophisticated mechanism to analyze. And when are you going to launch it? The mass production of this vaccine will take you weeks. So in summary, if you give a vaccine, your body will take anywhere between 4 to 8 weeks to give an antibody response. You start checking it then. Therefore, nature cannot be cramped. If you put science in front of your chariot, you will be overrunning it and the science will be dead. You cannot cramp a marathon into a 100-meter sprint. Yes, we need the COVID vaccine, but it has to go through a scientific process which you cannot avoid.
Dr. Bagai, effectively, would you say that this deadline of the 15th of August, is this a political deadline or a medical deadline? And do you believe medically this is irresponsible?
You know, at my age and with lack of hair, I have learned to keep away from politics and all controversies. That's the only way I can save the few strands which are still left. But this is complete fiction. This is fantasy to the highest level. I don't think this is a realistic deadline. I don't know what the political or the bureaucratic compulsions are to issue that letter. The person who's written the letter is a good friend of mine. I'm not entering into anyone else's domain, but all my take as a summary point in my first part of my suggestions are this would take a better part of 3 to 6 months at a minimum before it comes on to mass use into public. I don't think 15th August is a golden hairline which we have to keep. I have no problem if the vaccine comes up, let's say 15th October, 15th November, or January next year. But it has to be something which is going to give an immunity to a larger section of population. That means the efficacy, that means the immunogenicity. Without that, we are just chasing a shadow in the dark.
Yes. In fact, Dr. Bagai, I will come back to you to talk about how globally as well, there is a sort of a race that might not actually be very ethical.
Just a last quick point, and then I'll allow all the others to through you to talk on this. Is apart from administration and management for many decades, for the last 36 years, being a practicing clinician in pediatrics, I don't think there is any person apart from pediatricians who have more hands-on knowledge and expertise and personal experience in using vaccines. So it's more than 3.5 decades. I personally have used more than 25 different vaccines, which are routinely used in children. And mind you, when you talk in terms of vaccination, the first thing which comes to mind is pediatrics and children. 80-90% of the vaccinations are in the pediatric age group, 0 to 18, although adult vaccination and adolescent vaccination is a huge chunk. Geriatric vaccination is a huge chunk. So through my own personal experience, I think we need to be cautious. We can't cramp or avoid certain processes. It's better to be on the safe side, delayed by a couple of weeks and then launch. But keeping a deadline on or before this would be really tough and stiff for the people who are making it.
Very well explained, Doctor. Thank you so much for that. Dr. Joshi, do you agree that right now this seems unrealistic, and would you tell us why, please?
So, Faye, thank you for having me here. And I think the whole thing is, I think it's a typographical error of 2021 and not 2020. I personally feel this whole suggestion is, and I tweeted on this also, and I maintain it, is like Usain Bolt running in 5 seconds, not 10 seconds. So ICMR wants to do some Guinness Book of World Records, or it is ridiculous, to be very honest. You can't expect a phase 1, phase 2, phase 3 program of a vaccine development, which normally, as you rightfully said, takes a decade, and all my worthy colleagues and my good friends have said, to be fast-tracked in 6 weeks. I think this is nothing short of fiction, as Dr. Bagai very rightfully said. I want to highlight a very basic element.
Yes, please.
To know the status of immunity, we need to know the amount of neutralizing antibody, which is IgG. And currently, we do not have a single test in India which estimates the IgG in a quantitative way. We need the neutralizing titer of antibodies. Right now, all the tests which are the antibody tests, which had a lot of controversy and which were delayed and deferred, which have just become commercially available just a week or 2 weeks back, which are necessary even for our plasma donation, none of them give me a quantitative estimate of neutralizing antibody with a titer, which is critical for evaluation of efficacy of a vaccine. In absence of such a validated assay, I am absolutely stunned that how is this possible? Now, probably this is a collaboration between Bharat Biotech and ICMR is keeping something very close to its heart in a very secretive way. And maybe they have done all this mathematics and homework to break a Guinness Book of World Record. Best of luck to them. God bless them. I really feel this is something has gone wrong somewhere there. Either it's a typographical error, it at least defies my medical mind completely that this is not possible, this is not doable. And if it is doable, it is nothing short of a medical miracle. We are governed by a Magic Remedies Act in India. And I think 6 weeks is too tight. To measure any vaccine efficacy, I need to have a valid quantitative titer of an IgG antibody. I'm sure the NIV has already got that assay in order. They have the best scientists on planet Earth. They have the best trained biologists on planet Earth. And I wish them best of luck. that they really can be the Usain Bolt when in a vaccine development, as Dr. Bagai said, it's a marathon. But if you can run a race of 100 meters in 5 seconds, best wishes to them on our Independence Day. But I really feel it is more fiction than facts.
In fact, Dr. Joshi, I just want to point out, because I looked at this suggestion that this is a typographical error, but the year 2020 has been typed twice in that letter, where it says that it is envisaged to launch the vaccine for public health use by 25th August 2020. And in this thinly veiled let's say, ultimatum that's been issued to these organizations, it says you are strictly advised to fast track approvals related to initiation of the clinical trial and ensure the subject enrollment is initiated no later than 7 July 2020. So that would have to be two consecutive typographical errors.
I think they are worthy. If they meet that deadline, they are worthy of a Nobel Prize for this year.
All right, we have, of course, Dr. Mahapatra as well, who hasn't spoken. Dr. Mahapatra, we had this conversation earlier as well about how we were actually, as a country, not researching the strain of virus and its behavior among our people enough. Is this an example of that? The fact that we lack the sort of rigor in the trials and the research?
Maybe, but one interesting thing that actually surprised me about this announcement, I have never heard, read, or even dreamed about an announcement of a vaccine being available in the market even before its trial has started. So how come somebody will know that when something will be available in the market? Because as Dr. Bagai, just like a textbook teaching, explained all the viewers about the phases of a vaccine trial, before in different newspaper articles and all other announcements, we are getting to know that the study has not yet completed its phase 1. If the information is not delayed, that already they have finished several phases or something, crossing phase 1, phase 2, phase 3, and then post-marketing trial and having that available in the market within this period, what does that mean? We don't understand. Most interestingly, I'll request all of us and our viewers to visit the CDC website, where it clearly says that the SARS coronavirus antibodies appear after 2 to 3 weeks, if we are talking about IgM, IgG together. Now, 3rd July or say 1st July to 15th August doesn't cover that particular period. So if we are injecting somebody a killed virus for getting their vaccine response to be developed for a particular phase, one of those phases, that will not even be over by then. So I don't think it is a lack of research, it is basic knowledge that such a faster availability of a vaccine through all those phases is not ever possible. Probably it's little misarticulation of some of the interpretation that there were several research talking about in a pandemic situation. Do we need to follow all the phases as it is in the textbook? Is there any kind of leeway to have different kind of adjustments to handle the pandemic situation? Recently, there was a paper in NEJM talking about this very nicely, talking about all such kind of things happening during H1N1, 2, Ebola, and all those stuff. It was talking about when some developed vaccines were kept on hold for public use and what was the negative part of it. So that was one spectrum. And while actually interpreting that spectrum in the light of the need of the hour, it is some kind of overshooting from 6 weeks to 14 days. So this is kind of, I believe, risk communication and public health communications are very important component of public health management. And we need to be very careful about that, because since morning till now, I have received maybe 150 WhatsApp messages to understand what does this mean. And the point is, I don't know what does this mean. I hope it is a misprint. I hope this is something which is not actual reality which is going to happen. I hope that already several phases have been completed, and ICMR was waiting to be sure that there is something which is working. Definitely, it is worth Nobel Prize. Whoever comes up with a vaccine, given the amount of lives lost over the planet. But I am not expecting a vaccine in market on 15th August.
All right, so this is what we know, the fact that there are many stages of testing a vaccine. There is a lot of work to be done, and it doesn't seem humanly, scientifically, medically possible for all of that work to be done in the short span of time between today and the 15th of August. Secondly, that there isn't enough information that the ICMR has released on what this virus does, where it can be used. And thirdly, and fundamentally, we don't know enough about coronavirus itself, the COVID-19, in order to be able to action this. But I do want to ask a couple of other questions that are popping up from our viewers, one of which is the question about plasma therapy. Nature Lover has asked about plasma therapy, and so have several others. We now have the city of Delhi, for example, that's putting up a plasma bank and asking people to donate. Twitter is full of calls for plasma as well. Is there enough research to suggest this works? Because fundamentally, none of the doctors I had spoken to have been able to confirm, like Dr. Bagai was saying, that once you get COVID, you won't get it again. So is it like chickenpox? If I get it once, can I then walk around happily saying, hey, I've already had it, I'm not going to get it again? And if that's not true, what use is the plasma? So to any of the doctors who want to answer this question, does the plasma therapy work? Do we have enough evidence to suggest this is a valid route to take?
Whoever you
Can I
want.
take that? Okay, sorry.
Yes,
Bagai.
Dr. Bagai. Yeah,
No,
Dr. Bagai.
Shashank, please go ahead.
No, it's okay. You can go ahead. You are our.
All right. Okay, this is my job. Dr. Bagai first, and then Dr. Joshi.
Just before we come on to the plasma therapy, Faye,
Yes.
all the viewers, I want to make them understand that a vaccine production, the timeline goes in decades. So very quickly, chickenpox, what we call as the varicella vaccine, took upwards of 22 years of R&D and manufacturing and genomic studies before it came into mass use. H1N1, what we call as the flu vaccine, the annual flu vaccine, took upwards of 10 years. The human papillomavirus vaccine, what we call as the HPV vaccine to prevent cervical cancer in young ladies and women, it took more than 14 to 15 years. And mind you, there are some vaccines which the same company which is in question have made, and they have acknowledged it has taken more than a decade and a half. Out of this decade and a half, so to say, you could safely take out half the period as approvals, licenses, paperwork, and regulations. Fair enough. So you're still left with a better part of 5 to 7 years. Let's say, shrink that down a little bit more, make it about, shave it off a little bit more, maybe 3.5, 4 years. Squeeze it a little bit more, make it about 3 years. You really sit on it and push it out of shape, make it 2 years. 6 weeks, then I'm Richard Gere and everyone else is Julia Roberts. It can't happen like that. No, it really can't happen. Coming back to your question on the plasma therapy is almost been used internationally for the last 100 odd years. It was first used in early part of the last century for diphtheria. It's used in 2003, 4, 5 in SARS and MERS, even in Ebola. So really the principle is that you're giving antibodies which are taken from patients who have recovered, and you're putting it back into human beings who require that antibody to fight the antigen which is COVID. So in a way, you're giving a principle of passive immunity, but you're giving it in an active form. So you're giving ready antibodies. So your body of a patient suffering doesn't have to manufacture it or doesn't have the time to manufacture it. So it's a good move. At the present moment, it's still under trial phases. I think Bombay has one of the largest studies which have been set up. Shashank can expand on the Bombay experience. In Delhi, it's been set up in one of the hospitals of ILBS. The people who are donate generally about 16.5 to 17 days after you have got the COVID and recovered. So that's the period of time your body takes to build an adequate amount of antibodies. And it's given under supervision. Of course, you need a specified laboratory for cell component separating and a plasma separator. It's given in certain volumes of 200 ml. You need neutralizing titers. Not all laboratories in India have that. So there is no point in giving plasma when you don't have adequate amount of antibodies. And here is the study which I had quoted in the first part of my talk, that a larger section of people who have recovered actually do not have the adequate antibodies. So I think it's still early days. It's shown promise. What it really does is 4 or 5 very quick points is it gives you an immediate clinical improvement. So your oxygen requirement goes down. Your total number of days and stay in the hospital in the ICU decrease. Your ventilatory requirements and pressures which you require to keep you alive decrease. Your radiological picture as far as your pneumonia or your cytogenic storm is concerned decreases. Your interleukin levels and tumor necrosis factor levels, all your cytogenic storm, all your difficult markers in your body show improvement. And there is approximately a 21 to 22% mortality decrease. So far, whatever studies we have in hand internationally, it's shown good promise. Within the Indian scenario, we are still to have a very large collective cumulative data. I think Delhi will have large numbers, Bombay will have large numbers too. So it's something where people should voluntarily come and give. Yes, if it is not plasma, we would have people receiving whole blood otherwise, and we will have the red blood cells used for other people. So I think as a duty and moral responsibility towards India, I think blood donation is a good thing. But plasma therapy, it's in early days, it's shown promise, but clearly it's not a silver bullet in which every patient can receive it at any given point of time. The earlier thinking was it's only for the very bad, critical, last stage of COVID. Now it's also being used for moderate to severe, not only just severe. But still, the data is still coming in. So really, we still have to wait for the final word.
Yes, thank you so much. In fact, we've had another question pop up from one of our viewers. Techro says, why not then just use plasma therapy instead of a vaccine? So Dr. Joshi, do you want to answer that question?
Sure.
Is there a difference? Yes, go ahead.
Yeah, there's a big difference between the two. So plasma therapy has to be given for people who have COVID, while vaccination is given to people at large. So that's a very big difference between the two. And plasma therapy, one of the largest trials in the world, is going to be done in Maharashtra state. And we are very proud of that. And I think there is some places where we should congratulate ICMR also. So I have to compliment and congratulate ICMR that they actually in their guidelines, almost 15 days back said, you can use plasma therapy as an off-label therapy. See, remember that after 28 days, as Dr. Bagai rightfully said, the antibodies develop. And after 28 days, a patient who has recovered from COVID donates the blood and has an adequate titer of the neutralizing antibodies. It can be life-saving. The right time to use plasma therapy is when somebody does a 5-6 minutes walk test and desaturates, has a COVID lung, has a cytokine storm setting. You give him plasma therapy, it can be virtually life-saving. So it can be used in moderate and severe COVID. Just like vaccine, we need safety. So do we have safety data? The Mayo Clinic, from which I am originally from, has published 20,000 patients from United States documenting safety of plasma. So plasma safety is established. Now, is it effective? So the first report of 5 patients where they saved lives in New York City, which came in the JAMA, clearly showed that it is life-saving. The results were mixed. In Mumbai city, it was given in compassionate grounds, including to bureaucrats and many other people who were unfortunate people who got COVID, and they are all done very well, except for a few exceptions. So remember, plasma therapy is possible. It is a very good option to be looked at from a research mode. And I think as any other hospital beyond the research centers also, off-label can use plasma therapy for an individual case on a compassionate ground. So I think this is a clear case for moderate COVID, severe COVID, critical COVID, and it's a ray of hope, which is a realistic ray of hope. I would not say it's an experimental ray of hope. It's a realistic ray of hope. And it is tested more than century. See, blood donation is something which is very well documented. I know for certain there's going to be some amount of antibody as long as I'm able to quantify it. So I think it's a very welcome thing. And I think Mumbai, Delhi, and all parts of India and geographies which are having saved lives and mortality is high, it will clearly dent the numbers. We want to get our mortality below 1%. And if we want to get to that number of below 1%, plasma therapy will have a huge role in that if done appropriately and correctly.
Very well said. Now, Dr. Anant, I wanted to ask you this question. Now, we know that overseas as well, many of the approval, the regulatory organizations are speeding up their process in order to get the vaccine out as quickly as possible on humanitarian grounds, so that people can go back to their lives and the number of deaths will come down. But you pointed out in your tweets this morning that you believe there is an ethical issue with what the ICMR is doing. Could you tell us why you believe that?
Sorry, yes, so absolutely there, it's good to want to expedite things, especially at times of a pandemic. All of us are very keen on seeing a vaccine come through because it's really required right now for reasons which were well described earlier in our discussion. But that cannot be at the cost of following the protocols which are there for vaccine development. So you cannot be hurrying through these phases because, as was very excellently explained by Dr. Bagai and Dr. Joshi, it takes time for many of these responses to happen, including your immune response. So until you actually study those and you have enough data to show that safety is there, immunogenicity is happening, there is an immune response which is being generated, there is no level of confidence you can have that you can see a protective response to the vaccine. So if we were to actually then want to see all of that data being played out and actually being registered, analyzed, you would require enough time for that. And it's an ethical requirement. I mean, you cannot not do that and then say, we are going to skip those steps and directly go and announce efficacy, which is what is likely to happen if you're going to announce something on the 15th of August, because there is, it looks highly unlikely that you will be able to get all of your data in place of all of these phases in a confident manner and be able to present that on by 15th of August sequentially as well. So I think that's where the ethical issues also are, that if you are not following due processes, if you are not ensuring that all of the standard requirements of conducting vaccine research in a proper protocolized manner are being done, then you are going to be taking shortcuts. And that is not something we should be doing, because the kind of science we should be doing right now, yes, it can be expedited in terms of taking, trying to ensure that the regulations are efficient, they're implemented in a way that unnecessarily delays in approvals are not happening. But the basic requirements of doing science and doing it in a proper way and ensuring that the data that you collect is scientific in nature is not something you can take shortcuts on. So again, that's where my concerns are, that given that we are working with the study which is across multiple sites in India, that this is going to be very difficult to do in 45 days. And by 15th August, expecting that to be done seems very, very unlikely. So, pretty much fiction, as other panelists have been.
Dr. Mahapatra, go ahead.
One more point to what Dr. Bahn said, that we are only talking about the vaccine's efficacy and effectiveness. We also have to talk about the vaccine's safety and tolerance part. Yeah, it's a killed vaccine, so probably it is not likely to have the problems that generally the live vaccines have associated with these, but that is very less amount of information for a disease vaccine, for the disease for which we don't know anything actually. There is no clear idea about the pathogenesis of the disease so far. There are all kind of speculations, and those are gradually generating evidences in favor of speculations, definitely. But we are not in a position to talk about anything more than those speculations. Given all these, without having those efficacy trials being well supported by the phases, when we can understand the solicited, serious, non-solicited, non-serious, all kind of adverse event, it's actually not something where we should commit that is already ready for the market. That is another ethical issue.
Also, I have a question about the sample size that's normally used to test a vaccine and the kind of different types of people who are volunteers. The ICMR continues to refer to them as subjects, but volunteers in a trial. What are the numbers that are used even for phase 3? And does it seem likely, with the kind of, let's say, impatience that ICMR is displaying, that we will be able to do trials on these many candidates?
So there are different terminologies, subject, candidates, and all those stuff. Yeah, definitely vaccine trials start with the volunteers, but in the stage of phase T. The goal is to understand the safety as I was talking about, and safety is required to be tested in a large group of population. And in this phase, it is also important that we have to understand other factors associated with that part. Everything is not in ideal scenario. In the initial phases, things occur in an ideal scenario to assess the efficacy. But if the adverse event happens in 1 in 10,000 and we are actually having the sample size less than that, we may not by chance get them, some of them having that adverse event. So to detect a kind of a proper, significant, statistically significant amount of these things, we have to have several thousands of subjects to be tested within days. And something below several thousands, more than nearly 500,000 or something, it's not really easy to have a vaccine like this to be in the market. So
Right.
we need to test this in a larger population generally to understand all the adverse events.
Right. Just a reminder to our viewers, please remember to use the super chat feature, support myself and my team. These are difficult times for journalists as well. It will be easier for us to make salaries and be able to bring you conversations like this if you support us financially. To take the same question to the rest of the panel right now, there are different candidates of vaccines being tested across the country at this point. I'm curious to know why this particular candidate was the one that the ICMR decided to back. Is there any clarity on that? Because there are other organizations, AstraZeneca, for example, is working on a vaccine as well. Why is it that this particular vaccine is the one from Bharat Bio that the ICMR decided to back? Does anyone want to hazard a guess?
Can I take it?
Yes, Dr. Joshi, go ahead.
I think this is a collaborative project. So I think the strain is coming from the National Institute of Virology, which is ICMR. And they collaborated for vaccine development with Bharat Biotech, which has the domain knowledge of making vaccines. But just one day after the Drug Control General approved this vaccine, also Zydus Cadila, which is an Ahmedabad-based company, also got approval for doing trials for their own vaccines. So I think let us be very fair to the regulator in that way, that there are many made in India, make in India compounds, which will be made by vaccine manufacturers. And you rightfully said that Serum Institute with the Oxford University has collaborated for the development of the Oxford vaccine. But those trials have started, I think, in South Africa and United Kingdom and other parts. India is not a part of that trial domain. I'm very happy that ICMR has got its strain into Bharat Biotech. It's a very welcome gesture. As long as they do the development of phase 1, 2, and 3 ethically, appropriately, it is very welcome. And I also wish best of luck to Zydus and many other Indian majors which are developing this. So I think this is the reason ICMR, it is a joint venture. If you see it very carefully, it is a joint venture where the strain and the lot of development has probably come from the ICMR and has been co-developed with Bharat Biotech. So it is actually the Indian scientists from a research lab collaborating. It's like NIH in the US collaborating and doing the trial with Moderna, which is another vaccine candidate being developed in the United States. Similarly, it's a very welcome gesture that just like NIH and Moderna are collaborating in the US, in India, ICMR and Bharat Biotech are collaborating, as long as their deadlines are meaningful and make some clinical common sense.
I saw Dr. Bahn's hand go up as well. Go ahead, Doctor.
No, I was just going to point out, yes, that I mean, the reason for that, as Dr. Joshi rightly pointed out, is that the vaccine strain comes from the National Institute of Virology, which is our apex virology research institute in the country. And that is obviously a good enough reason to go ahead and want to do research. I mean, it's also a national priority right now for various reasons. As we know, COVID-19 has been devastating on many sectors of the Indian economy and also has had huge implications on the health sector. But that does bring in an element of conflict of interest as well, because if you're a co-creator of a vaccine, you would want that vaccine ideally to be proven efficacious. So, you have to also manage that conflict of interest. So ICMR, obviously, we would want this research to go forward in a proper way, and hopefully it will be shown to be efficacious, and we will see that vaccine in market at some point of time. But then you also have to recognize that ICMR also has an interest here because they are the co-creator of the vaccine. So you need to also ensure adequate independent oversight of the vaccine development process, the R&D process, the clinical trial, to ensure that there is no bias which is creeping in. And part of that is ensuring that adequate time is given to all of the phases of the clinical trials so that they are done in a proper manner and that they are not rushed through, so that the data that we are seeing is reliable, it's something which has been analyzed well. And based on that, we are taking decisions about even potentially, policy rollout of the vaccine at some point of time. So, again, we are all supportive of ICMR working in this domain. We are supportive of Indian science, but we need to ensure that we do it in a proper manner so that, as and when we have that final data about efficacy of the vaccine, we can all trust that and we be absolutely confident that this is something which would be useful for our population.
Well, before we run out of time, there's one more question I'd like to place before the panel, and that's this. I had a conversation with someone with a doctor from Chennai who represented the IMA, who said, and I was a little worried about the number of cases going up in Tamil Nadu. And his point of view was what can be done? We have to unlock at some point. You can't keep the country locked down. Herd immunity will take its course. Now, I want to understand from this panel, where is the scientific or and the medical research to confirm such a thing as herd immunity? And if it does exist, is that then the solution that we're going for?
Can I take that, Faye?
Yes, Dr. Bagai, go ahead.
Okay. Just a rundown, even on this full issue of herd immunity. I think this full herd immunity is turning out to be a herd mentality. And that's exactly what we don't want. Okay. More than 36,000 articles in the last 4 months have been published in international reputed journals. And the reason I'm mentioning this is because 61% of these articles were withdrawn within 2 to 4 weeks of them coming into print. So the reason why I'm mentioning this is science cannot be compromised, the results cannot be compromised. Otherwise, we ourselves will become a fundamental threat to truthfulness and information. It takes time. And in medicine, first thing which we have learned is do no harm. So we have to be patient, we have to be cautious. In trying to save lives, we cannot take lives. I think that fundamental fact has to be understood. And I want this message going to every medical professional, every doctor, every scientist. Never lose your own power and your own right to ask questions. Because you have to have that belief that you can critically analyze any data, any publication, any article. With regards to herd immunity, what really herd immunity means is that a large section of population in a given society, so it need not be a nation, but a given society. So it can be a region, it can be a large district, it can be a very large area. More than 55, some are saying 60, but the recent data is between 60 and 70% of the population should develop immunity. There's a very beautiful paper which is published by Center of Science and Information Technology by Sunita Narayanan in Delhi last month, in which the only city which has reached 19.2% of immunity, that's herd immunity so-called, is New York. So we are nowhere near gauging whether we can reach 60 to 65 or 70% of a given population to develop immunity. And I must add in the end, the phrase of herd immunity can only come in when you test a large sample size. So with the type of test which we are doing, we are only identifying the positives, and almost 45 to 55% of the international population, and including Indian population, are asymptomatic carriers. So we have no grasp of information on that. So I think the full concept of this herd immunity, we should just put it into the locker room and keep it shut till we actually come to grips with masking, sanitizing, and social distancing. I think these are the only 3 things which will save us. I still feel vaccine is many months away. We will touch base on 15th August morning again and take a rundown on where we stand as far as this is concerned. But we just have to keep cautious, keep our guard up.
Yes. In fact, for the rest of the doctors as well, where do you believe we stand on the herd immunity? And my question is, if we're going to actually get infected to the tune of 60-65% of our population, and out of that, if 20% is going to be symptomatic, will our healthcare system be able to handle that kind of load? Because even that, if a sliver of that number is a massive, massive number in our country. Dr. Joshi?
Faye, a couple of things. I think I agree with Dr. Bagai that herd immunity takes, we are in the first cycle of the virus and the first season of the virus. It takes at least 6 to 8 seasons for any virus to actually know what is the immune and how the immune response is. We need to know what is the primary attack rate, what is the secondary attack rate. Nobody's asking those questions. I'm sure we have an elegant public health expert in Dr. Mahapatra who will tell you what is the primary attack rate, secondary attack rate. You know, we have these antibodies which develop. They are a long way away. We need a good, at least 4 to 6 seasons to understand the basis and the disease. We have a virus which is not even 6 months old, and we have started discussing herd immunity. I'm only going to talk one point and I'm going to close out. That is that Sweden tried this experiment of herd immunity and it bombed very badly, where their ministers, most of them lost their posts. United Kingdom used to have these virus parties when they were common cold parties. And I'm also hearing in the United States, they have started in Texas, some virus parties. That might have been true for common cold and flu, but that is not going to occur for corona. And I think it's a very preposterous proposition. So I think for at least a good 4 to 6 seasons, this herd immunity can be parked out. Yes, we will develop some antibodies and we will have some antibodies generated, but we need to understand better. We are doing fast tracking, and I'm sure that in times to come, we wish that whole India is immune and this corona goes away, but that's wishful thinking. And I think it's times which will tell us, but I think we need to wait.
What would be a season for coronavirus? Are you expecting it to come back in next year?
Absolutely. So every season has a virus coming up. So if winter is over and summer is over, we are in monsoon now. So the next season has started. Corona came in India in spring, then we had summer. Summer is getting over and monsoon has started. So with every season, we'll understand the natural history of the disease. For any illness which is infectious or non-infectious, we need to study the natural history of the disease. And we need to study the primary and secondary infection rate. Unless and until we do those basics, we can't jump the gun. So I think we will get a lot of answers in times to come. We are in a hurry. In science, we will always be in a hurry because it's pandemic. It comes once in 120 years. But as Dr. Bagai said, that almost 70% of the research has been retracted or not published. So we need to be a little cautious and have a little more scientific temperament from a public health standpoint. Thank you, Faye.
Dr. Mahapatra first and then Dr. Bagai.
Yeah, just very briefly, as Dr. Joshi said, this is very important that all these things are actually used, the terminologies are used not as a kind of a breaking news, but also should be as a scientific aspect. Like the way we are using the herd immunity, it is just like we press a button and we get the herd immunity achieved. We have to understand that herd immunity is something which is achieved through several planful interactions between health system as well as community level responses. And we need to understand a disease like this. We are actually, unfortunately, although there are several good examples are there, what we have seen in different parts of our country regarding the pandemic response. But overall, there is a lack of coordination in all this knowledge dissemination as well as knowledge processing. And I believe the pandemic response design should have been led by epidemiologists and doctors, but somehow all the task force and all kind of information sharing is happening in a sporadic way. We need to understand that whenever we are dealing with such a disease which has such a virus, which has such a high infectivity but such low pathogenicity, we have to be very careful. We are dealing with a very virally fit virus, which is an intelligent virus, and it is also dealing with an enzyme which is known to make viral folly. So whether vaccine or whether the antibody response, those are not so easily predictable. So we need to understand that how we can have our health system, the question that you asked before, we need to have health system preparedness, predicting the kind of challenges that we can address and take it as a learning to ensure that all these things, the surveillance, the testing, the health system response, and then coupling the vaccination development process together into a policy which should be a corona control program in our whole public health system.
I saw Dr. Bagai's hand go up as well. Go ahead, though.
Just very quickly, Just about 3 days back in one of the states in US, they had a huge COVID party, late night COVID party of about 30 odd youngsters and teenagers, out of which many of them are in the ICU and 3 of them are on a ventilator post this COVID party. And they thought that let's infect each other and so then we'll develop immunity and we'll be safe. In 1970s, much before the MMR vaccine came in Australia, there used to be rubella parties. That was all the young girls who never had rubella were asked to stay in the same house for many days till they cross-infected each other. But rubella as an infection and COVID as an infection are two very different ball games. So I think this herd immunity is many months, many years away. We should not be talking about it for two reasons. One is it's too early to talk about it, and two, we don't have a sample size of a larger section. We are only testing a very minuscule percentage to actually gauge a herd immunity. My last take on this way, and then I'll excuse myself, is our next 4 weeks is going to be very critical. I'm not going into whether it's in community spread or not community spread, because I think everyone is taking this as a ominous sign. It's more like it's a poison word if you say community spread. And if one person says it, then the other person has to say, no, 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 it's not. The fact is we are in community spread. Now, whether it is or it is not is immaterial. We need to prepare as we are in community spread so that our action and responses are accordingly trimmed. Our next 4 weeks are going to decide what's really going to happen to our healthcare system. It's being stretched, yes, at the present moment. We are creating a large amount of beds. We are creating stadiums into hospitals, hotels into hospitals, parks into hospitals. But unfortunately, beds can be bought and manufactured. Doctors cannot be manufactured. It takes a better part of 10 to 12 years for a person with reasonable amount of experience to be managing these kind of patients. So I think a lot of doctors also are with comorbid conditions. Doctors are not gods. Doctors themselves, a lot of them are beyond the age group of 60, 65, who cannot come in front line. Doctors themselves have comorbid conditions. A lot of doctors have diabetes, hypertension, and so on. They can't come in front line because they are themselves at very high risk. So our workforce, our functional workforce to fight this battle and the front line is that much lesser. So I think the only way forward is if as a community, if we spread the message that we all have to become mask warriors. We all have to become an SMS warrior. That means sanitize yourself, keep clean. Please wear a mask. Do not take a risk of not wearing a mask. There is enough data to show that if you are an asymptomatic carrier and you've not been tested, you have a very high percentage chance. Can you believe it, Faye? The recent studies have shown one asymptomatic carrier can infect up to 1,000 plus in 14 days. 1,000 plus. So you were talking of, not you as you, but we were talking of an R naught of 1, 2.2. That is the infectivity rate of how it can go on. The fact is, if one guy can infect 1,000 others, then the 1,000 others go and infect another 1,000 others. That's your community spread. So we have to keep social distancing for many months. We have to keep masking for many months. And I think this should become a fashion statement. This should become ingrained in our psyche that we are not only doing it for ourselves, we are doing it for our country. Longer we remain in a suspended animation, it's not only going to hurt our healthcare, it's going to hurt our economy. So I think with that note, I will take your leave, Faye. I've been pulled in different directions. And
yes. I guess, thank you so much for giving us your time, Dr. Bagai. I'm always very grateful for your time. I want to give the last word to Dr. Bahn, though. Here's my question. What do you expect over the next couple of days? Do you expect some sort of messaging from the ICMR saying that, hey, this is not what we meant, it was a typo, this is, would you say clarity right now from the ICMR would be welcome?
Yes, I mean, as our premier biomedical research agency, I think it's imperative that they clarify things. And, it's okay to accept that there might have been a mistake, that they might have overestimated the speed with which they could do things. It's better that they do that. I mean, rather than, pushing through and being aggressive about this issue and saying, no, we will want to deliver on it and let's try it out. because that could potentially put people at risk, that could put the folks who are involved and the institutions who are involved in a lot of pressure, and we wouldn't want that. Let's do our science right. Let's ensure that we protect our research participants, we do our research in a proper manner, in a way that we can be confident about the way it has been done, the data that we are getting from it. And it's okay to make mistakes. All of us are under a lot of stress right now. We are all anxious on wanting to make things happen. So, I think it would be, for ICMR as the agency which sets the standards for these countries, both on ethics as well as the way we should be doing our research, it would be imperative that they follow those same standards as well.
All right, doctors, thank you so much for your time. Before we wrap up, I do want to thank all of my audience members who've been kind enough to support us. Tanvi Desai, Raju Surendra, Viju Paulse, Sonai Muthu, Niral Gutan, who's donated twice, Siddharth Hariprasad, Akash Singh, Nutan Burman, Ashish Saxena, Shaurya, Chandrima Sham, and Sushil Singh. Thank you for being so generous. I think that it's important for us to also realize that while we are getting fried at home, because now we're in the 4th month of this lockdown, almost as July has begun, doctors on the front lines have now been in PPE for 4 months. It is exhausting. There is a severe level of fatigue that is building in, because that initial phase of let's do whatever it takes and work through it, I don't think anyone expected that it would go on for this long. So we have resident doctors who are worried about their final exams, they're worried about their future, they're worried about applying for the next phase of their lives. We have senior doctors, all of whom have been doing this non-stop for 4 months, and we should keep them in our prayers and our minds. We should be extremely kind to doctors when we encounter them in any sort of social situation, in the grocery store or anywhere else. These really are people right now who are going above and beyond anything that could have been asked of them. I will leave you with, I will repeat what Dr. Bagai said. The SMS method is the vaccination for the time being, because any real vaccination is going to take much longer than the 15th of August. So sanitize, wear your mask, practice social distancing, almost as if it is a new way of life. Keeping yourself safe is really the only vaccination that is available to us at this point. And our entire healthcare sector, I'm sure, would be grateful if we just followed these very simple rules and kept ourselves as far as possible out of trouble. All right, thank you so much for being part of this panel, to all of my panelists, to the doctors, and thank you for the work that you have been doing. I've been tracking your work over the last few months, and I know that it is beyond superhuman. I thank my audience as well for joining us every day. Remember, we'll be back. Tomorrow is Saturday. We won't have a panel, but I'll be here on my regular Saturday Live. We'll do an AMA, we'll answer all of the questions, and we'll talk about everything that's happened during the week. So join us tomorrow as well. Stay safe, stay home, and thanks for watching.
Thank you.